Thank you everyone for logging in to our Wellness Wednesday live webinar. This is a platform focused on health and wellness with guest speakers and specialists answering your questions about physical and mental well-being. My name is Zarmina and I'm delighted to be on this journey with you today. Today we have with us Dr. David Chin. Dr. David is a consultant ENT surgeon with subspecialty focus in rhinology. He has extensive experience in the management of patients with nose, sinus, and snoring problems. He currently serves as a member of Board of Examiners for ENT specialist training in Singapore. Thank you so much for being here with us today, Dr. David. How are you doing?
I'm doing great. Thank you very much, Zamina, for having me today to speak about something that I'm very passionate about, especially the opportunity to speak to more people. Sometimes I have to do it one-on-one with patients, and it's a great opportunity to share and to discuss. So I'm very happy to be here, and let's take it away.
Sounds great. Well, you're absolutely right. We have people signing up for the session as soon as they see the keyword, whether that's snoring, allergies, sinuses. These are very common things that all of us can relate to. And we definitely got a lot of interest coming from that background. So I think just to start off, can you tell us a little bit about yourself? What kind of conditions do you treat? What motivated you towards a specialty? And what exactly is rhinology?
Okay, so we start. Essentially, I'm an ENT surgeon. So everyone knows ear, nose, throat. That's easy to understand. But as with all specialties, there are subspecialties as things progress. So my special interest is in the nose, conditions of the nose and sinuses, and surgery of the nose and sinuses in particular. So I think going back, a lot of people wonder what motivates us to do a particular specialty. So in ENT, I think one of the main things is that we get to treat patients both in a medical way and a surgical way. So often in medicine, you're either a doctor, as a physician, or a surgeon. And ENT is one of those specialties where you actually get to do both for different conditions. And so you sort of have the full spectrum of treating patients from the beginning to the end. The other thing is that when we're training, we are always very excited about learning new surgical techniques. And ENT is one of those areas where we get to do in the normal open surgery. We get to use scopes inside the nose, for example. We use microscopes for microscopic fine ear work and things like that. So it's a very, as someone embarking on a career, it's a very, very exciting specialty to be in. So my background then is, after I became an ENT surgeon, I said I needed to further in the subspecialty of the nose and sinus that I wanted to do. So I spent a year doing a hands-on fellowship in Australia with world-renowned surgeons. And then they did mostly sinus work and endoscopic skull-based work. This was about 10 years ago. And it was also the time where endoscopic surgery of the nose was at its, just developing to its peak, where it was possible to approach the bottom of the brain through the nose, where in the past they had to make open incisions. So this was what was motivating me back in the day. I think just stepping back a little, in terms of rhinology, the other thing about rhinology is that, it's actually a very, very common condition. And as you mentioned rightly, a lot of patients are concerned about allergies, about sinuses, about snoring. And these are questions that we face each day, and the patients sometimes don't even know about these conditions. So we take a step back. We actually do reach out to a lot of people, and it's possible for us, if we reach out to patients, that we can help many of them. So I think these are the things that drive people like myself in my area. A lot of the knowledge has changed in the last 20 years. I would just summarize to say that, for example, in terms of sinusitis, the prevailing idea back in the 1990s was that something external has come into our system, and usually bacteria, and we focus on that. And today, whenever a patient comes to see us for sinusitis, the one thing that they want to tell me is that how many bouts of antibiotics or courses they've been on. And the fact of the matter is that the research has caught up with us. It's showing us that actually it's not so much what comes from external, but it's how our immune system is not balanced, or it's not in the right state of regulation, that allows sinusitis to persist. So research has caught up with us. We still haven't got that message out to the vast majority of people. So I think that's really exciting as well.
That's great. And you mentioned the use of antibiotics. Just a question there. Are you finding that there's an overuse for treatment of certain cases when it comes to sinusitis of antibiotics, or is it, within reason?
I think you're absolutely right. It's just that for most people, even many doctors, the idea of having an infected system would suggest that there must be a bacteria there, and if we kill that bacteria, everything will be fine. But obviously, the truth is much more complex than that, and it is being overused. If we go by the most recent guidelines, so a lot of us follow the European guidelines, and they came up with a recent update last year. The reason why we do that is because that consensus brings together almost people from almost every part of the world, and it brings the experts. They discuss, they produce, they go through tens of thousands of documents to come up with their recommendations. And when I tell my patients, surprisingly, for sinusitis, for most sinusitis, taking antibiotics is not really going to make a difference. It's very hard for me to say that when all along from their childhood, from their GPs, from people they hear about, it's all about treating with antibiotics, killing bacteria. So it's quite a challenging process sometimes to get that message out to patients, and sometimes just we often have to meet their initial expectations of what we're supposed to do in order to convince them. So I think it is overused. There's big concern about overuse of antibiotics all across medicine because of we continually hear of increasingly resistant bacteria. We have to keep producing stronger antibiotics to meet that need. And I think there's got to be an end. We're going to hit the limit someday, and then we'll be in trouble. So I think we should actually save the resources for really important infections that need to be treated by antibiotics. And that's a message that we need to get out to our patients every single day.
Absolutely. Well, thank you for shedding light on that. Dr. David, we know that millions of people globally suffer from allergies every day. Sometimes they're entirely unaware that they may be allergic to something or what they may be allergic to in actuality. What are some precautionary steps one can take to be more aware of their sensitivities?
I think the first thing is for people to understand that it is a very, very common condition to have allergies, and allergies can affect in different ways. So on the skin, you see manifestations in dermatitis. For us, particularly, we're interested in what happens in the nose and sinuses. And a lot of, even when I was growing up, I expected it was normal to wake up with a sniffy nose, sneeze a bit, sometimes get blocked, and that was just part of life. Um, but that's because we didn't know any better. I think these days the information is all out there. In most developed parts of the world, the statistics suggest that it's between 10 and 20% of people who have allergies. So the first thing is just being aware that this might be happening to me. The second thing is to understand that it is a common condition. It's treatable. Most patients are eminently treatable, and if you manage these conditions early enough, then you can get a good quality of life, prevent other conditions from developing. Um, so it is quite different in different parts of the world. So classically, when people talk about hay fever, that's because in springtime, you get the plants, they're blossoming, and then they start to get all the symptoms. And that's why it's called hay fever. So in temperate parts of the world, I don't know what it's like in Dubai, but certainly in Europe, North America, South America, you get that very typical pattern. And then the rest of the year, it's not so bad. But if you live in the tropics, then we don't have seasons. And so we're getting these symptoms day in, day out. It might not be every single day. It could be 2 times a week, 4 times a week. It varies. And the difference is that the kind of allergens that people in the tropics are exposed to are more stereotyped. It is much more likely in many of the patients in Singapore, for example, or tropics, that even if we don't test them, we can guess that 3/4 of them are going to be allergic to dust mites.
Okay.
So it's just being aware of that. I think that's the most important thing. And one of the biggest misunderstandings or misnomers or people relating symptoms of nose is that we all like to use the word sinus to represent everything that happens in the nose, whether it's a true sinusitis or an allergy. And I once thought this was particular to Singapore, but even when I was in Australia, even with the colleagues that I speak to in North America, elsewhere, the
Mm.
most common way patients describe is I have sinus, and that's supposed to mean everything. And it's part
Mhm.
of our job to then differentiate between what's allergy and what's an
Yes,
infection.
right. So, what would you suggest? What would you recommend is the best way to identify an allergy? I know there are those prick tests. Is that the best way to go? That if I'm somebody like me, I'm not actually sure what I'm allergic to, what precaution or what step can I take?
So I think it's easier if you live in the tropics, because as I alluded to earlier, I can predict that most patients are going to be allergic to dust mites and maybe oil palm or a few other things, cockroach, that sort of thing.
Hmm.
So if resources were unlimited, we'd definitely test everyone. Skin prick test is probably one of the most popular. It correlates very well with the symptoms in the nose. It's very safe as well. So essentially, what people get is that we call it a skin prick. That actually no blood's drawn. It's hardly painful at all. And if it's positive, that allergen will cause what's very similar to a mosquito bite. It gets swollen, it gets itchy. So
Hmm.
we use that as a means of identifying what someone is allergic to. What about the practical value though? If all we're going to do for example, in Singapore is to clean my house, make sure that we have a low level of dust, use filters, and use medications to control the symptoms, then there is no specific value in knowing that I'm allergic to dust mites, and I could have guessed that. But
Hmm.
if someone is looking for a cure, and there are cures for allergies, then that becomes important. Then in the US, North America, it's been popular for many decades to use various types of immunotherapy. So if you're allergic to maybe 5 or 6 different types of allergens, you can administer that over a period of 3 to 5 years. And if you start to get the results that you want, you can actually change the way your immune system reacts, and you can virtually get well, it's as good as we can get to a cure, maybe about 85%. So in that kind of setting, it's valuable then to obviously know what you're allergic to so that you can give the appropriate specific treatment for that. So
Right.
that's where it's important, I think.
So that means that they're introducing that substance that you're allergic to in very small controlled quantities in order to help your body kind of absorb it.
Exactly. And typically, the simplest way these days is to use what we call sublingual drops. So let's say I've identified I'm allergic to dust mites, cockroach. Then I could get those specific allergens, put them into a solution, drop them under my tongue, leave it there for 1 or 2 minutes a day, and that small exposure over time
Mhm.
gets into the immune system and changes the way that it responds. And so we start to produce a different kind of antibody that doesn't elicit all the symptoms that we normally get. And so we can usually see the effects maybe over a period of 6 to 9 months. But if
Mhm.
we stop treatment at that stage, it's just going to come back. But the research has shown that if you carry on 3 to 4 years, then you get that long-term benefit. It's pretty similar to buying life insurance where you pay your premiums for a number of years, and then you're guaranteed another 20 years of your
Yeah.
insurance against a mishap. So it's a similar kind of concept, but yeah.
That's great and very promising. Thank you for sharing that with us. So also when it comes to allergies, can they be mistaken for asthma? I mean, I'm someone with asthma and I've had it since I was a child. And growing up, new doctors would always say, no, maybe it's allergies. And then, they would kind of explore that for a while and then realize, no, actually it's asthma. But I often hear it interchangeably sometimes with people who aren't so aware. So they kind of just, mistaken it or think that maybe it's like you said, hay fever, or they're triggered by different things, maybe dust. But we also often hear that allergies can trigger an asthma attack, but asthma can be present in some people without allergies. So how does that work and what's the correlation?
Well, that's exactly right. It's just the terminology that we use when doctors talk about asthma. They're talking about the way the lower airways react to a trigger. It might be an allergic trigger, it might be an infectious trigger, or it might be intrinsic. So the most common scenario is that if we have a patient who has got very strong nasal symptoms of allergy, then there's a higher chance that that person may or at least some proportion of those patients will develop asthma. And the same triggers that affect the upper airways that go further towards the lung, they're going to have the same effect on the airways, except that in the lower airways, it's going to be narrowing of the airways. It's going to be, so that's causing wheezing, shortness of breath. They might cough because of the reactivity. So that's the classic view of how an asthma develops. But of course, if we define asthma as just the wheezing, as the reactivity of the lower airways, then we can sometimes see patients who don't fit that classical definition. For example, in ENT, we have groups of patients who are in their 40s. They develop nasal polyps. They can't smell things very well. Nose is blocked. They haven't had the classic allergy symptoms when they were in their teens and 20s. And if we ask them, they start to develop this thing called late onset asthma. And so they're not reacting to something that's external anymore. It may not be, but if we check, and the research has gone the last 15, 20 years, tons and tons of research looking at the inflammatory mechanisms that underlie these changes. You can see the changes that are in the lining of the nose and the lungs. They're similar and they affect each other. So that's one of the concepts that came about, is this thing called the United Airways concept, where, even though doctors are divided into ENTs for the upper airways, respiratory specialists or pulmonologists for the lower airways, the fact is that when our system is affected, everything is affected. And if you treat the nose well, you treat the sinuses well, it helps to improve the asthma, and the other way around as well. So that's another example of how sometimes it's difficult to classify asthma, and it's not always due to the common allergens that we talk about. And also, again, in medicine, it's often this, we give names to things. It's either this or it's that. But as time goes on, the research is showing that it's usually not either this or that. That's the classic. And in between, you've got a big gray zone where when you have a person who's predisposed to having asthma, for example, but only gets it when he has the flu or something else triggers it, that is not an allergy. So, and some proportion of those patients then eventually go on to have the classic asthma that just comes out of the blue without any trigger. So I think it really is understanding how these things interplay, and then treating each component separately. But if they have a common cause, then attacking that together. So I think that would be my answer to why it's easy to get allergies, asthma confused. There is a strong overlap.
Right. No, thank you for clarifying that. I mean, it helps me a lot, being somebody who suffered with the classic asthma. There are times that it has gotten confused for allergies. Let's focus a little bit on snoring. I feel like that was a very big interest for our viewers today as well. And the number one most common, question and area of interest is, how can one know if their snoring is a sign of a bigger problem, such as sleep apnea or sinus infections? How would one recognize that?
So I think snoring is a very, very important topic, and I think you've hit the nail on the head. Absolutely. The moment we have snoring, it's sort of saying that your upper airways are not stable anymore. You're getting some turbulence. There's some narrowing there. At the early stages, it may just be noise. That's possible. But if again, it's the whole scale. On the other end of the spectrum, you may have a situation where the airway is getting blocked for a significant proportion of the time someone's asleep. The problem is that when someone's asleep, whether they're in deep sleep or shallow sleep or just in between, or between that and wakefulness, they have no way of knowing what's happening. And usually what comes to light traditionally is the person that is sleeping with the person who's snoring is the one complaining. Usually a wife. Yep. My husband is snoring, can't sleep, I got to put earplugs, that sort of thing. That was traditionally how it surfaced. And so we then have to work out, is this significant or not? So there is a way of doing that. We rely on what we call a sleep study or polysomnogram. So it's actually a study where during sleep, we're measuring oxygen, airflow, the heart rate, beat, the brain wave, so we can tell which stage of sleep the person is in, snoring. And you can put all that data together, and then you can come up with an index. And basically what we're looking for is the person's sleep being disrupted by, in particular, periods where there's not enough air getting into the airways. And we define that as not breathing for 10 seconds, for example. That's one event. And if you have inadequate breathing, like oxygen drops, airflow drops by maybe 30% for 10 seconds again in a half-minute period, we count it as one. So we count all these things on the computer. Thankfully, you've got computers to help now. And you add it up over an hour, and then we arbitrarily have had an index, or how many times an hour means mild, moderate, or severe. So when you do a sleep test, then you'll know, is it just snoring and I'm just making noise? Or is snoring the tip of the iceberg and I'm actually getting obstructed 50 times an hour, which is one of the common things that we see. And so what's the implication of having sleep apnea then, which is when your breathing actually stops? It actually makes your heart work harder. So we're imagining that, and we all know how sleep is important. I just want to bring this anecdotally that a lot of my patients now have these tiny wearables that are, or watches that are monitoring their sleep, and the only sad thing is that the ones who are monitoring are the ones who are least likely to have the major problems. The ones that have the snoring and sleep apnea, they're not doing that. But essentially, when we sleep, everything, the whole system is meant to be resting. But what happens when we have the situation where we have to breathe harder is that our heart still has to pump the same amount of blood at the same pressure. So it actually has to work harder. And over time, this leads to high blood pressure, hardening of the arteries, a simple way of explaining that. And you can understand that with the other factors that usually come together with someone having sleep apnea, these factors come together to then add on the risk of having high blood pressure, heart disease 10 years later, and 20 years later getting strokes and vascular problems. So snoring is then the start of when we should become at least aware or concerned about checking for these things, and then making the changes or interventions to limit the amount of future damage or risk that might come out of that. I think the other part of your question was how it relates to sinusitis. So essentially, I forgot to bring up one main point. Now, when we're med students, we all learn that newborn babies are obligate nasal breathers. That means they can't breathe through the mouth, essentially. If they do that, it doesn't work very well. And the reality is that when we are asleep, not just newborn babies, but everyone, ideally, the only correct way to breathe is through the nose. Because when we open the mouth, what happens is that the tongue tends to drop backwards and makes things even worse than it was before. So if someone has a blocked nose caused by allergies or sinusitis, for example, then they're not going to be using their nose optimally when they're asleep. And that's going to make things worse, essentially. So that's how it relates. Snoring doesn't cause sinusitis, but sinusitis can make snoring worse or cause it to be surfaced.
Absolutely, that's very helpful. Thank you for clarifying that. I see we have a couple of questions coming in about snoring, so we will get to that in the second half of the session. I would like to ask you, Dr. David, in the current global situation that we are all facing, majority of the population have had to or will have to undergo a PCR swab test for COVID-19. I've been through this process. I found it quite uncomfortable. Though it can be superficially uncomfortable, let's say, are there any side effects of, taking the swab test, or maybe too frequently if you have to do it for your job or for travel or for other reasons? Are there any side effects or anything one should be aware of?
I think you're absolutely right. I just saw a patient today for the second time. She was absolutely convinced that her recent nose block got triggered because the person who did the swab for her was too enthusiastic. And so, yes, I've seen patients who have had nosebleeds after nose swab. I think actually, by and large, for the number of swabs that are done, it's actually a very safe procedure. And obviously that there are benefits to doing it, far outweigh any of the risks. And I don't blame the people who are doing them, because unlike ENT surgeons, we get to see noses thousands of times over years, and we can sort of feel where it's going. If everyone has an average nose and they did it gently, and that's how I think most people doing swabs are taught to do it, the swabs are actually very fine and soft, flexible. They're not going to cause much damage. It is very uncomfortable, no doubt about that. Even when we put scopes into people, we know it's not the most. I've done it to myself. I know what it feels like. So as uncomfortable as it may be, I think it's safe. If someone is aware, some of us may have a nose that is bent inside, and that means if someone puts the swab straight back there, you're going to encounter that. That's obvious, I guess. And if it happens once, then I think if it's my nose, I'd say, hey, look, the last time I had this done, I think the guy ran into the problems on this side. Why don't you try the other side? I think that's the simplest thing you can do,
Yeah.
short of educating or showing everyone what the inside of the nose is like.
Mhm.
So I think by and large, the risk of things going wrong, I think is pretty low. And I'd just like to encourage everyone just to persevere. Maybe we'll find a better way to do a swab in time to come,
Yeah.
but just be patient. So I think as far as swabs are concerned, until we find a better test, that's all I got to say. Maybe if we all had availability of anesthetic sprays like ENTs do,
Yeah,
then it could make things a lot easier, I guess.
true.
And
So
yeah,
does that mean somebody with a deviated septum might have a little more of an uncomfortable experience?
yeah. If that's the case, then it'd be wise to choose the other side because often when you get a deviation, the other side may be a bit more favorable, but not always. Yeah.
Interesting. Okay, no, that's great. So let's take our last question before we jump into our
Okay.
live questions. So again, related to the pandemic, for individuals who have gone through COVID-19 or are suffering COVID long, including loss of taste, this could be a painful cough or other similar symptoms. What can they do to ease their lingering symptoms and achieve a recovery?
Yes, it's absolutely right. A lot of patients then have various lingering symptoms, and I think one of the ones that caught the attention of a lot of people at the time was the sense of loss of the sense of smell. I think that's the one that became very, very, very prominent. It's not new. I think interest in other subtle, what I call subtle functions of the nose has increased over the last 10 years. I think if you asked 20 years ago, our biggest problem was blocked nose, discharge, all the big stuff. But now there's a bit more finesse. A lot of research is coming out from Europe. We do understand that when people lose the sense of smell after flu or influenza, sometimes it's very hard to get that back. But that's also prompted research into testing for sense of smell and also training. So there's this thing called olfactory training, where not all hope is lost when you lose your sense of smell. There's a number of factors that go into what's happening. Maybe the nose is blocked, and that's quickly reversible. We all know that. Sometimes there's inflammatory changes in the nose, and really the smelling part of the nose is right at the top here. So the chemicals for smell have to get through all the way up to the top without being obstructed. And even at the level of the lining of the nose, there has to be a clear pathway. And then, of course, if there's so much damage has occurred that the nerves have been sort of disrupted or destroyed, there is still a chance. The great thing about humans, I guess, is that there's this thing called neuroplasticity. Things can grow back. You can maximize the function of what's remaining.
Right.
So if I extrapolate from research that's been done into training for people who have lost their sense of smell after a flu, then one suggestion would be to do olfactory training and do it as long as it takes to maximize what you can get. Most research has gone up to 3 months.
Okay.
And what they've done is the patients have been asked to, or the research compares people who don't do anything and those who do this training. And they give them strong smells like cloves, rose, lemon, and they get them to smell it and to meditate on that and try to remember what the smell is like and to use a very strong smell so that they can detect it first, and then as things get better to progressively use less intense smells and it has shown that there's a definite improvement for patients who do that. So I think that's probably what's the probably from the ENT point of view, that's the most important long-term side effect of having suffered COVID. So I know it's difficult. I think especially now, initially, a year ago, our concern was whether we're going to be alive or not going to be alive. And then obviously we've seen that many people have survived that. And now our focus is on how to help people who are going through or who have gone through it. So I think
Right.
there can be a shift in the focus. I'm
Absolutely.
not sure if I've covered all that you spoke about. And I don't
Absolutely.
know if the analogy applies to, I don't know if the listeners can understand that analogy. It's just the same as someone who has had a stroke. And if he didn't do any training at all, that the hand that was not working is never going to work again. But we hear of, with rehab training, they can get function back. So it's a similar sort of thing. We're going to make use, and we got to do it early. If we wait 1 or 2 years after the event, that's probably too late.
Right. So kind of like physiotherapy after, an injury, just work on it sooner than later.
Yeah, absolutely right. And it's probably going to be very pleasant if someone can't smell anything and suddenly, ooh, I can smell something. I think that will be very, very encouraging. I think, and it's not so. Yeah.
Absolutely. Well, that's great. Let's jump into some questions we're getting on all ranges of topics. So we'll just take them as they are coming. So
Okay.
first one, this is a great point because you did briefly touch upon the endoscopy. So we have a question on whether endoscopy can be done as a precautionary screening. Would you recommend that if it's not medically advised? Should an endoscopy be done, once in an individual's lifetime just for the sake of it?
I think it depends on what disease we're looking for. So, for example, if you're screening for allergies, for example, we don't actually need to do that. You can usually get a history. A doctor can look through the nostrils and make a good guess. I would take one example though. This is a classic example of nasopharyngeal cancer, or what people commonly call nose cancer. So in Southeast Asia, Southern China, this is one of those things that we've been talking about for maybe decades. Should we do screening for, because it is one of the most common cancers, or it was one of the most common cancers in middle people in the 30s and 40s. And by the time it shows up with blood or blocked ear or some lymph nodes, it's usually stage 3. So the only way that you're going to be able to find it is by looking through the nose right at the back. So that's one situation where doing a screening is probably going to be helpful because there's no other way to detect it early. Right now, we only do screening for patients who have a family history of this cancer, or
Okay.
who, and also some patients turn up with bleeding, and because of that, a blood test is done as a screen, and then we figure that there's a risk and there's a need to do that. But I think in most of the other conditions that we see, inflammatory, allergy, infections, usually the first thing that happens is some symptoms will appear. And I think from that point of view, there is no strong need to do a nasal endoscopy for screening. That's that's a bit different from doing a sleep study to check for snoring, though. I think that's a
Mhm.
different thing altogether. That's often missed, and maybe that's something that we should be striving for, increasing awareness. I'm digressing here, but I'm going back to snoring again because it's such a it's a
Yeah.
it's a it's an it's going to be epidemic in many societies in time to come as we get older, as people get bigger.
Yeah.
And yeah. So I hope that answers the question about endoscopies now.
Absolutely. And actually, that fits in great with our next question. We have somebody asking about the correlation between snoring and being overweight. And I feel like this is something that I've also heard from time to time from people that if they've seen a specialist for snoring, they've been recommended to lose some weight, as that would have a positive impact. So, what is that correlation there?
It's a very, very strong correlation, especially in adults, but even more even so in kids now who are overweight. But I just take the classic example. So we know snoring and sleep apnea is caused by some narrowing in the airway. So if you take the typical child with big tonsils and a blocked nose from allergies, that child doesn't have to be fat or thin. You can easily open up the airways by taking out those big tonsils and clearing out the nose. And most of the time, you get a good result. Now, if you take the average typical 50-year-old man who's enjoying life now and having better food and has been putting on weight for 10 years, and now starts to realize that he's got high blood pressure and snoring, that in that patient, if we did exactly the same thing, and if we did even more, we wouldn't necessarily get a good result. And that's because when we look at the airway, it's not the tonsils or something inside the airways that's causing it to be narrow. We can see that it's actually narrowed from the outside. And obviously, that's a lot to do with the overall weight that they have been putting on. We also see the clues from the kinds of people that get diagnosed with obstructive sleep apnea. Very uncommon do you get skinny people having that. If they do, they usually have a very, very small jaw or a
Mm-hmm.
super blocked nose. One of those things that adds on factors that were beyond their control.
Okay.
Yeah, and the other thing is that when treatment is done for patients who are on the thin side, the outcomes are usually much better. So there is a very, very strong correlation. And for this reason and many other reasons, we should all strive to be as thin within the normal range as we can be.
Right. No, that's great to shed some light on that. We have another similar question on snoring, and that's about the correlation between snoring and smoking. Does being a smoker impact my likelihood of snoring and having other issues such as sleep apnea?
Oh boy, this is a rather tricky question. When it comes to smoking, smoking, I don't think directly causes sleep apnea uh, as a factor alone. I don't think it does, unless the person has, as a result of that, a very blocked nose, for example, and that causes him or her to open the mouth to breathe. So it's not that I'm encouraging smoking, but I think the correlation between smoking and sleep apnea is not so strong, not directly anyway. So
Okay.
is that I hope that doesn't encourage our listener to smoke more.
I hope not. Disclaimer. No, we have a very interesting question which actually crossed my mind about allergies earlier on, and I'll just summarize it because it's quite long. So, people develop allergies later on in life, sometimes to things that they've been enjoying since childhood. Maybe that's seafood or shellfish or anything like that. So in this particular case, shellfish was given as an example. Why do allergies develop at a later stage in life? And does that mean that because they develop late, they can be reversed and you can go back to your normal way of life?
It's extremely difficult question. I would put a disclaimer that not a lot of research has gone into looking into this. Although I do agree that we do see a lot of patients who are finding out that they're allergic to a certain substance that they're eating, usually a food allergy. This is so different from the inhaled allergens that I was talking about before. Um, I don't think Western medicine has a very good explanation for why these things happen. It seems like often the issue is too much of a good thing usually ends up causing trouble. And
Yeah.
so I do see patients who have a different sort of profile. They did maybe all the skin prick tests for the inhaled allergens are negative. Their
Mhm.
symptoms seem to be, like you say, coming on later. And sometimes when you do look into their diet, they find that there's something that they actually like very much, and it keeps. And I think that putting too much of that in the system somehow upsets the balance of the immunity. And
Right.
so there's also other theories. For example, there are some patients who have nasal polyps and allergies of the nose, for example. And there is a condition where part of the inflammatory system has got a hypersensitivity to aspirin, for example. So we call it aspirin exacerbated respiratory disease. So that's an entity. But there are lots of foods that we eat that have got natural chemicals or elements that do the same thing as aspirin, but in a less obvious way. So that's one possible pathway for that. If you eat too much of that food, then you're putting a lot of that into the system. So I apologize. I don't have a really an easy answer for that, but there is some truth to that, and hopefully in time to come, research will answer our questions on that. But don't take too much of a good thing sometimes.
Absolutely, that's a great reminder. I think we all could use that. And you mentioned a key point of allergens from food as opposed to other substances such as dust and so on. So, is there a different test that can diagnose that, or is it all, fall into the category of a prick test, skin prick?
Yeah, so I think the feeling is that the food allergens need to be tested in a slightly different way, because the traditional skin prick test for food, I'm now differentiating between full-blown allergies, like you take nuts and the whole thing all swells up. That one, if you do a normal skin prick test, yes, you will get the result. You can do that. But I think the kind of allergies that a lot of people are experiencing, they go through a different pathway. We can see some spillover effects in the skin prick test, but um, they are more subtle, and sometimes they involve doing a skin test as well, which is intradermal. So we have to introduce it deeper into the skin to elicit that response. Sometimes we get clues from doing a blood test looking at antibodies and comparing that with a whole range of things. So if most things are 0 and another one showing 10, 15, which under normal circumstances is still considered classified as normal, then there's a clue that something is going, and that particular thing you're eating is maybe causing this problem. So I think it's, again, food allergies need to be tested differently. It requires a lot more detective work on the part of the doctor and the patient himself, looking at what they're eating and how that relates to the symptoms.
Okay. And staying on allergies, why are some people born with allergies and is it genetic?
Um, I think it's probably not fair to say they're born with allergies. In the classic example, for example, allergic rhinitis, in most patients, it only starts manifesting at about age 3, 4 onwards. In the first few years, the inhaled allergens don't play a big role. So as with many, many conditions, genetics affect how easily we develop that, because there's always this interplay with your genes. So it's multifactorial. It's not one gene, but it's a combination of many genes. So you can't blame just one parent or both parents. It's all your extended family and beyond that. That's one aspect. And the other aspect is the nurture part. So how are we exposed to the environment and what happens there? So interestingly, in developed countries, the incidence or the number of patients who develop allergies is much higher than in countries that are not so developed. And in countries that have developed over a period of time, when they compare the statistics from before development to after becoming very urbanized, they find that the rate is much higher. And one of the theories is that in our immune system, we produce these IgEs, immunoglobulin E, which was traditionally meant to target parasites and all other kinds of nasties that come. In the urban world, we don't have to face these parasites. So the system seems to become, it's got something else to look for to target, and that's the theory. And so a lot of our kids now don't spend a lot of times outdoors, do not get exposed to a lot of normal bacteria that helps to guide our immune system. And one of the other things that I'd like to say beyond that is that a lot of research going to look at the gut microbiome. There are billions of trillions, I don't know how many bacteria in the large intestine. And it's now been found that those bacteria have a large impact on many, many things, on allergies, how fat or thin we are, and what disease susceptibility we have. So, and that brings us back to the point of antibiotics. If we take too many antibiotics, it's not just that we're breeding resistance, we're also killing off all the multiple variety of flora that we have with us that may be helping us.
Great. No, thank you for that. And I think that's, like you said, it's so timely to bring up the gut microbiome because there's so much these days around us about gut health. Could you just touch a little bit about the importance for that and how much attention we should really be paying to our gut health?
I think it's really, really important. From a purely scientific point of view, as with all Western medicine, if you have to look for research, I think the biggest examples comes from our gastro colleagues. They're looking at things like inflammatory bowel disease, which is a very lifelong, difficult condition, and lots of patients suffer from it. And it's caused by inflammation, but what's the cause of it? And so, if I'm not wrong, this is not my specialty, but I understand that looking at the gut microbiome from patients who have the disease and there's those that don't, there's a vast difference. And what they've done is they've done a poo transplant, and we call it poo transplant. It sounds disgusting, but actually taking the poo from normal patients and putting it in these patients, it's actually in experimental cases found to be helpful and sometimes can even resolve the issues. So that's one example. I don't know if there are experiments for other diseases, but we can sort of extrapolate that. And And this change occurs right from the moment we are born. I've heard of research where just comparing babies who are born normally and babies who are born by cesarean section, the gut
Okay.
microbiome is already changed because they've either passed through the birth canal or they've not. So these things, while we
Okay.
may put it down to genetics, there's actually the moment we come into the world, things have changed already. So I think there's a lot more research that needs to go into it. Does it mean that we all should go and buy probiotics and eat them? I guess if we've come to that stage, maybe we have to, but just think about the probiotics that are being offered to us. They're just maybe 10, 20 varieties, but the
Mhm.
natural world has millions and billions of different types. So it's
Right.
harder to replace once it's been destroyed.
Right. That's a great way to put it, and thank you for sharing that with us. A few more questions we can address. Dr. David, is it normal to be prone to nosebleeds? Is that something one should be worried about?
If one has had nosebleeds many, many times over a long period of time, I think that's a good sign to me. I'm going to explain why. I've been like, when I spent time in Australia,
Mhm.
climate's dry, I bled once every 2 days. And so, but the thing is, the first time it happens to someone, they're going to be worried. Do I have a tumor inside there? Do I have cancer, especially in our part of the world?
Mhm.
So, yes, it's good to have that checked out. Most of the time, though, nosebleeds caused by an area of the front of the nose that is prone to drying in the repeated trauma. So imagine if I've got an itchy spot on my hand, every day I scratch it, it gets
Mhm.
irritated, bleeds a bit, crust, and then it gets better, and I do it again and again. Same thing happens in the nose. And often the underlying reason is that there's a slight bend in the nose, and that side being the convex side, just like the wing of a foil of an aeroplane, the wind air flows quickly, dries the area, and you get a repeated process. So
Okay.
that's one common thing. So it's, I guess it's not normal to have nosebleeds. We all don't want to have nosebleeds, and it's very inconvenient and sometimes scary.
Mm.
It's just good to have it checked out, and sometimes they can be resolved quite easily. Sometimes if you have that situation, you just need to take care of it, just like we take care of the rest of our bodies.
Great, thank you, and I'm sure that was very helpful. We have another question. This is an interesting one because I think
Mhm.
I can relate a little bit to this. Is it common to have a runny nose for undescribable reasons? So for me personally, I don't know this person's scenario. And I love spicy food. So if I'm having something spicy, it's standard. I need a box of tissues next to me. Sometimes it's even, after I get ready and I put makeup on, my nose will start running immediately after for a short amount of time, nothing that serious, but it's pretty regular, I would say. And I'm guessing it's pretty regular as well for this viewer.
Yeah, yeah. So I've experienced all of those things, so I can relate to them as well. I think if we try to put it into boxes, the first kind of runny nose that you describe is non-allergic. It's a natural response. Anything that is irritative to our nose, be it something nice to eat, is
Hmm.
going to cause that reaction.
Okay.
And it's up to us culturally to decide what's acceptable and what's not.
Yeah.
And then the other one that you talked about, when you have a short burst of runny nose when you're putting makeup, that might be occurring at the same time every day. And I
Hmm.
think that's more likely to be allergic. And it sounds to me like it's on the mild side, but it could
Yeah.
be different for different people.
Right.
So it is common. It's very, very common. I'd say probably 5-10% of people regularly have that. In some places, maybe even more. But it also changes at different stages of a life. I think the children, teenagers have it more prominently. People
Right.
in 20s and 30s tend to forget about it, and people in their 50s, they just get a blocked nose more than anything
Hmm.
from the allergy. I hope that answers that question. It is common. It's not normal. If you want it to be treated, it can be treated in most cases.
Great, that's wonderful. And we will take our last question of the day. And this one, I think there's generally, in today's world, a lot of interest and questions around COVID. So I think this is a very relevant one to end the session with. And
Mhm.
that is there any screening that I can undergo post recovering from COVID-19? And just to add to that from our side, being based over here and being based in healthcare, once some individuals recover, they're quite concerned with their functions. Are their level of functions back to normal, right? Are they operating as well as they were before COVID. So, is there any kind of screening or proactive approach that one can take after having recovered from COVID-19?
Okay, I got to say a caveat. The number of cases in Singapore is pretty low, so it's hard
Okay,
for us to have any direct, patients to speak about.
right.
But I think in general, I just heard some really, really interesting research that came out yesterday on COVID, and it seems that when you have competing viruses, the rhinovirus being the most common cause of a cold,
Mhm.
um, and they've done these experiments, compared that with putting coronavirus, and it seems that having the rhinovirus around actually makes it harder for coronavirus to have its effect. And so I just heard this yesterday, and
Okay.
it's going to be intriguing. So I don't know if there's anything that we can do. It's not like I want to go and get rhinovirus so that I don't get coronavirus. But I think that in time to come, apart from vaccination, if we have the necessary general health to back up our system, then
Mhm.
probably the manifestations will be less. I'm just saying this. And one of the other interesting things that I heard, just looking at big studies across the world, I think this was an association that deals with obesity. And they said they think the reason why in some countries the death rate has been a lot higher is because those are the countries which also have a higher BMI on the average. So why is it that, for example, in India, there was this worry that, oh my goodness, it's spreading around, but the mortality rate is so much less than the US and the UK, for
Right.
example. So I think just um, taking your health and taking good care of it in general is probably going to be the most useful thing that anyone can do. Anything else that's more specific, apart from a vaccination, is probably going to be hard.
Mhm.
There, I do want to add one thing though. Now there are, if the virus comes through our nose, as it often does, there have been products that have been produced that form sort of increase the barrier between the what gets in your nose and what gets into the lining of the nose.
Okay.
That's one of them. They're made from a seaweed product, and it's very safe. It has been proven in other sorts of nasal viruses. So I think anecdotally that might be something that people could do. But again, it's all conjecture here. No studies to back that up for coronavirus.
Well, thank you. That's a great reminder at the end of the day to, be on top of our general health and do what we can to remain in a healthy BMI, and other precautionary steps. Dr. David, I would love to ask you if you have a closing message for our viewers today.
Um, I do. I think I feel very strongly about snoring. I think don't ignore snoring. It usually means something is amiss there, and if you tackle it early, you have a lead time of many years before things manifest. Because
Mhm.
I'm seeing this happening in my country now. I'm seeing people come in 40s, 50s, and they have this problem. They've had it for a long time. It's always been around for years,
Right.
and my only wish is that they had checked it out earlier and taken some action to limit its effects. So I think that will be my take-home message for most people out there, most listeners.
Well, thank you,
That
Dr.
yeah.
That I think it's so important, like you said, to raise awareness. It's something so common, but perhaps maybe it's so common that it's overlooked at times,
Mhm.
and you think, oh, I'll wear my earplugs and sleep beside this person who's snoring without thinking, without thinking too much more of it. So that's a great reminder, and I'd love to thank you for being here with us today. We really appreciate it. And thank you to everyone who submitted their questions, who logged in for the duration of this webinar today with Dr. David. We hope you gained some interesting insight from today's discussion. If you'd like to see more of these videos, please check out and subscribe to our YouTube channel. And thank you so much, Dr. David. Wonderful speaking to you, and hope to have you on again soon. This was really wonderful.
Thank you. I really enjoyed that, Tamina.
Thanks.
Thanks very much for organizing this. Okay,
Bye.
bye bye.